Hello, my name is Dr. Matthew Lunning, and today I'm joined by Dr. Andreatis and Dr. Graf for a discussion on maximizing the possibilities and evolving treatment paradigms for relapsed refractory follicular lymphoma, from optimal sequencing to shared decision-making. We know that non-Hodgkin's lymphoma has exploded with regards to novel therapies. That has been the case in relapsed refractory follicular lymphoma also, and we're here today to talk about the latest evidence. We know over the last 4 years, we've gone from just chemo after chemo to now we have oral EZH2 inhibitors like tazemetostat entering the market. We then heard about CAR T cells getting there, with first being axi-cell and then followed by tisa-cell. Then we heard about this class which was going to revolutionize non-Hodgkin's lymphomas, our CD3, CD20 bispecifics, and we saw our first glimpse at exciting data with mosunetuzumab, and that led to the approval of mosunetuzumab. The surprise came with zanubrutinib obinutuzumab, classically not what you would have thought of from a BTK prior experience, but really robust experience from the Rosewood trial, leading to the approval of zanubrutinib and obinutuzumab. Now there's a second CD3, CD20 bispecific with epcoritamab that has entered the market in regards to relapsed refractory follicular lymphoma, pouring in some contrast as mosunetuzumab is a fixed duration therapy, whereas epcoritamab was developed as a continuous therapy. And now we have a third CAR T cell with regards to liso-cel entering the space in relapsed refractory follicular lymphoma. So it's now getting crowded. With the recent announcement that the approval was denied with odronextamab, our third CD2, CD3 bispecific. So just a lot, an onslaught of novel therapies here to try and help our patients that came to the clinical trial arena and now are out for utilization. Lots of movement in 4 years. I'm excited to hear kind of how each one of you are kind of working this into your practice. And we'll maybe start off, just kind of with those questions. And Tara, I'll start with you. We've seen a lot of movement in guideline recommendations for relapsed refractory follicular lymphoma. Let's specifically talk about third line treatment and beyond.
Yeah, so as you just presented, there's so many drugs now available, which is, fantastic for our patients, but also very confusing, for practitioners, right? What do you choose? How do you make the selection? And so I think now you really have to make it in a personalized manner, with your patient. Does a patient want to stay home? Do they need to travel? Especially being in a, say a community setting where they may not have direct access to the 3 CAR T cell therapies that you mentioned with axi-cell, tisa-cell, and liso-cell. So if you have a patient that wants to stay local, I think bispecifics with either mosunetuzumab or epcoritamab are, excellent choices. If you have a patient that really rather just take, an oral agent, there's tazemetostat, and, possibly even looking at Rosewood. I think we were very surprised, and it was a really good addition to the treatment landscape with the zanubrutinib and obinutuzumab. So I think, you can really make your treatment selections in third line and beyond, based on your patient and your patient preferences, because there are so many things available.
Yeah, I agree with you. I think the space has been just evolving very quickly, and it's been hard and to discern with your patients what are the next best steps. Babis, we know that all of these approvals have come through the clinical trial route, and that's typically how they get there. But we also know that once you get through clinical trial, we have to apply them to practice. And more specifically, as Dr. Graf just alluded to, bispecifics are likely going to be at our hands versus CAR T cell for many are going to have to travel. What was the data that led to both of these classes approval?
Yeah, so the good news is we live in the most exciting era in the treatment of follicular lymphoma because we have so many treatment choices. That's also the bad news, is that there's many treatments that we need to familiarize ourselves with. And they each have slight differences in their efficacy and their toxicity rates. There's some updates from the recent EHA meeting as well as the ASCO meeting in Chicago on these agents with data on mosunetuzumab proving pretty robust with longer follow-up with 60% of patients achieving a complete response. And that's pretty much consistent across subgroups. whether somebody's POD 24 or older. The only area where there's maybe a slight decrement is people who are in their fourth line of therapy or further, where they're showing slightly lower complete response rate and maybe progression-free survival rates. The data with T-cell pretty much mirrors the data with axi-cell with longer-term follow-up. So we're having about 60% of patients achieving a progression-free survival at 3 years. Data pretty similar, I would say, with the POD 24 patients. And then lastly, there was an update from Lysocell in terms of bridging therapy. We all kind of have hesitate to use bridging therapy with CAR T because of kind of some checkered history about affecting the efficacy rate. But the data suggests that for those patients that bridging therapy had to be used, obviously higher risk patients with higher stage disease or early progression, the outcomes were the same, suggesting that maybe bridging therapy helped improve outcomes for those patients. So I think the data are pretty much consistent with what we know and what we've been practicing with the last few years.
Yeah, I agree with you. I think bridging therapy has been a moving target. As we transition, we know these agents have a significant amount of efficacy, Tara. What about the safety profile of these agents that are now making it into the relapsed refractory follicular lymphoma setting?
I think what's always important when these agents have been studied in, different forms of non-Hodgkin's lymphoma, and then we, use them into a follicular setting, we see that there are really no new safety signals, which is always good to see, especially when patients are being treated, longer and longer. So you see here with mosunetuzumab, especially in that POD 24, that higher risk group, the rate of CRS 51%, which is something that we've seen with the initial data and seems to be continuing, but no new safety signals as these patients are on therapy longer. With T-cell, some notable AEs, grade 3 or higher would be neutropenia and anemia, which again is what we've been used to from prior presentation of safety. Most common SAEs, CRS at 20%. Again, this is not really anything new, but it just goes to show you that, as time goes on, we're not seeing, any new safety signals, and it remains favorable, which is really good. And same thing with Lysocell, obviously a newer kid on the block in terms of a third CAR T approved in this space. But again, overall, well tolerated. And again, the safety data suggests that bridging therapy may actually mitigate some of those AEs associated with the higher risk patients. So that's always good, to see that, when you're kind of trying to look at efficacy and then making sure the safety, is not somehow out, overshadowing that, I guess would be a good way to put it.
I think as a community, we've gotten better at managing CRS and neurotoxicity. We've gotten more comfortable giving agents earlier on. So across the board, we're seeing lower rates than were historically reported, I would say.
As we talk about kind of getting smarter, as commercial CAR T cells are now available with all 3 of them in the relapsed refractory space, as well as now 2 bispecifics at our clinical hands, how are we going to start to separate patients who have been previously excluded from the clinical trials, like those advanced age individuals, or those who their performance status may have knocked them out of clinical trials, but it was because of their disease and not necessarily due to some other comorbidity. What do you think about that, Babis?
I think I've personally done a good amount of work looking at real-world data with CAR T-cell therapy, and there's now many groups reporting on that internationally. I think the data pretty much pan out. The one consistent finding in all these studies is that anywhere from 40 to 80% of patients will not qualify for the clinical trial that led to the CAR T approval. But nevertheless, they derive pretty reasonable outcomes from this therapy. So if you look at recent data reported at EHA with axi-cell, you will see that driving again with my previous point that many of these therapies are better tolerated than they were when they first were approved, with very low rates of significant CRS. We're still dealing with grade 3 or higher ICANS in those studies, but the data, the incidence seems to be improving over time, suggesting that we are getting better at managing those. In terms of the bispecific antibodies, we definitely need a lot more data in the real world because these are, of course, newer therapies. They've yet to be to be used as widely as the CAR Ts have been used. Again, an abstract came out at EHA this year looking at the use of epcoritamab and comparing it to a historical database that focused mostly on response rates rather than toxicity. And it showed that epcoritamab, even compared with historical experience, produces really consistent outcomes in these patients with response rates in the at 86% and a CR rate of 69%.
Tara, do you think that there will be greater availability of CAR T cell and bispecific treatment kind of as it kind of emerges from the clinical trials out to the masses?
I do. I mean, and I hope so, because I think these novel therapies are excellent. They're excellent agents for our patients. When you look at the data, especially when you're talking about the third line setting, typically, as we know how follicular is, right? Those patients in front line have hopefully a long remission. And as they see subsequent lines of therapy, they don't do as well. But I think this is changing that. When you look at some of the overall response rates, we're seeing, upwards of 80% plus. And I hope that with the proper education, we can continue to educate and empower, groups across the country. And I'm going to speak specifically, from the community angle, but to use these agents and to be able to offer these therapies, to our patients, because I really do think that there's something to be said about, your own immune system and using T-cell directed therapy in this disease.
I can't agree more. I think there's been a seismic shift in the management of relapsed refractory follicular lymphoma. And with that, I appreciate everybody's time and hope that this has been very informative for you all. Hello, my name is Dr. Matthew Lunning, and today I'm joined by Dr. Andreadis and Dr. Graf for a discussion on maximizing the possibilities in the evolving treatment paradigm for relapsed refractory follicular lymphoma, from optimal sequencing to shared decision-making. We know that incorporating patient preferences and shared decision-making is incredibly important in relapsed refractory follicular lymphoma, especially around choosing bispecific therapy or CAR T-cell therapies. There have been multiple factors which may influence our treatment decisions, starting with the top of just our primary goal is preserving the patient's quality of life. We know that some of these therapies, like CAR T-cell therapy, may require caregiver support that may not be available. There also may be significant distance from the treatment center, and there can be long-term and cumulative toxicities that, as well as short-term treatment toxicities like cytokine release syndrome or neurotoxicity. But on the side of the bispecifics, there may be some administrative schedules where it may be frequent repeating doses, unlike what many patients are used to with CAR T-cell, which is the one-and-done approach. There also can be the advantages of convenience of administration, whether or not it's a short infusion or a subcutaneous dosing strategy, as well as access to the therapy with speed, with some of our CAR T-cells taking several weeks to manufacture, whereas bispecifics are now off the shelf. I think the ability to tolerate these therapies from clinical trial to commercial is only going to be seen because we aren't going to see head-to-head clinical trials. And so with that, and as part of the discussion, I brought two of my friends along, Dr. Andreadis and Dr. Graf, to kind of really tackle this discussion. So, Dr. Andreadis, are there any guidelines or recommendations for shared decision-making models in the relapsed refractory lymphoma setting?
Thanks, Matt. Yeah, as you pretty much hit the nail on the head, the follicular lymphoma is the quintessential disease where shared decision-making was established pretty much because there's many unknowns in the care of these patients. When do we start treatment? When do we switch therapies? How long can we wait between doing that? And the dearth of comparative data between different treatment modalities pretty much create a situation where there's many options at every step of the way. As we get to know CAR Ts and bispecifics a little better, I kind of appreciate the idiosyncrasies of each therapy, and I think we're better able to present them to patients in a more realistic way. I think, at least on my end, when CAR Ts first came out for these patients, that was the only therapy that had shown a benefit in the setting of chemotherapy refractoriness, and I was a lot more excited to recommend it. But now I find that much of the bispecific data can be pretty compelling and can offer a viable alternative, especially for patients who have different priorities or have problems obtaining care at our center. So I think the variety of options out there will only help patients choose better treatments that fit their lifestyles and their priorities.
Yeah, I think those are incredibly important points that you just made. And I think one of the aspects that's going to come about is really kind of in the shared decision-making model around certain aspects of social, economic, and racial backgrounds, and how that may impact your choice to have that discussion around the shared decision-making model. And how have you kind of tackled those aspects when trying to choose next therapy?
Yeah, and I'd be really curious also to see what Tara thinks about this, because I have a very skewed view of the patient population, right? So I practice at an academic center. It's a referral center for Northern California. I see a variety of patients who are referred to see me, right? So I don't see the broader denominator of relapsed refractory follicular lymphoma patients. And those patients sometimes may be local, or they may travel 2 or 3 hours to come to our site. So obviously, when I propose treatments to them, my experience is that many of the patients who want to be treated here with us opt for the therapies that are more time limited, whether it is a CAR T, that is a one-time therapy, or whether it's, let's say, mosunetuzumab, which is a fixed duration therapy, as few as 8 cycles. However, I do make sure I cover all the data and pretty much focus on what the outcomes are, but more importantly, what the quality of life looks like on those different treatments. Tara, I don't know if you have anything to add to that.
Well, yes, I do actually. I service a clinic that is 90 miles away from my hub, if you will. And, you know, the biggest thing that I've tried to do over the years is try to offer them the same state-of-the-art care that my patients locally in Des Moines receive. And so, you know, I have several of those patients who are on bispecifics, actually who are on trials. And what we have been able to do, fortunately, is actually provide them hotel stay and stay, you know, across the street from our treating centers. So we're able to offer them the same quality of care and the same, you know, the better care, right? The new innovative therapies without, you know, sacrificing that because of their geographical location. But I always use the example of my clinic that's 90 miles away, and that I have patients that are, you know, on the farm, you know, most of their time, who still want the best access to care and the best treatments available. And so we find a way to make it happen. But you're right, those patients do prefer, in a lot of cases, a more fixed duration therapy, and that's something to be considered with that.
I think that's a really interesting way to approach this. And so, you know, maybe I'll start with Babis. How have you walked through the discussion of both bispecifics and CAR T cells at your institution? And then maybe I'll turn it back to Tara and kind of talk through kind of how do you ask people to, you know, to travel for their CAR T cell. Babis, why don't you lead off for us?
Right. So many of the patients that come to us get treated on clinical trials. So of course, the clinical trials dictate the treatment that patients get. The patient that I just meet for the first time will have the option to do either of the two. And a lot of it has to do with kind of their goals of care and how much effort they want to put into these treatments. Many patients have important events to go to, or they've been through a lot of treatment already, and they're kind of tired, you know, because they're very early on in the recovery phase. So many of these patients opt for a treatment like a bispecific antibody because it's a gentler approach. It will give them more time to kind of catch up with their personal lives. Some patients, on the other hand, want to, you know, are very strongly for a one and done type of approach. And I think those are the patients historically who've gravitated towards CAR T cell. The good news is that the two options are not mutually exclusive. That, as we all know, we know that patients who have CAR T can respond well to bispecific antibodies. Now we're seeing some emerging data of the opposite direction. So I always reassure patients that, there's no wrong choice to be made, that one does not exclude going to the other. And I think that's what gives them more of a sense of being in control of their decision-making.
I think the great thing we're seeing with bispecifics and CAR T specifically in follicular is we're not really sacrificing efficacy, if we choose one therapy or the other. They're both excellent options. And I think what I try to tell them with CAR T is that, hey, listen, you're not going away for 6 months. You're not going away for, 3 months. This is not, an allogeneic transplant. You are going to go. You are going to have to stay, at the treating site for, approximately 30 days, but then you're going to come back home. I'm going to be your doctor. And together with your CAR T physician, we're going to co-manage you. You are going to come home. That's how I approach it. And, it usually really helps the patient understand, what's in front of them and the options.
Yeah, I agree that your approaches are both excellent. Babis, I'm going to tailor this question to you because I'm sure you've thought about how you have discussions around kind of how to get the access to novel therapies to all individuals, regardless of their racial backgrounds. But we know we haven't done a good job in clinical trials, kind of helping to answer that question. How have you integrated, this discussion into your shared decision model?
Yeah, Matt, you raise a very important point. As I'm sure you're well aware, there's many studies suggesting that U.S. patients in racial minorities have significantly lower access to innovative treatments, especially things like CAR T-cell therapy, largely because of obstacles to them getting referred to or coming to a tertiary care center. So we're always cognizant of those issues when we're presenting those two therapies to patients. There's also racial differences in the way people understand or incorporate the treatment decision into their lifestyle. So we always are aware that may be happening. So there are programs in place to try to improve access to these therapies.
With regards to, Tara, your kind of history of being involved in bispecifics clinical trials, well, what would you say to a community practice that didn't have that clinical trial experience, and how can they, work to gain access, for their patients, or what, ongoing initiatives do you have to expand your access for bispecifics and provide, good equity of care?
That's an excellent question. So I think that's there's a lot to that. One, first and foremost, from where I am very fortunate that we have had access to, multiple trials over the last 2.5 years. One trial specifically that comes to mind is actually the EPCOR NHL6 trial, which looked at the subcutaneous administration of EPCOR in the outpatient setting. This was an excellent example of, how we can have this novel therapy and patients truly can sleep in their own beds at night. We don't have to be in the hospital for any portion of this. Now, there are some requirements. They have to have very good safety education. They need to really be counseled. They have to stay close, so 30 minutes or less of the site of care for 24 hours after that first full dose. With bispecifics, we haven't really talked about this, but we do what's called step-up dosing, to introduce the drug into the system slowly so that for that first full dose where the highest risk for CRS is, they've got to be close. And really, majority of these patients are monitored and managed in the outpatient setting. And I think we have to sort of rely on each other. I think, community groups, this is the wave of the future, right? I always say it's the bispecific bonanza right now. And I think that education and just relying on what other groups have done and, helping from the procedural end to the actual administration and just talking to different, like pharmacists and physicians and nurse practitioners, from these centers that have done bispecifics, I think is really important.
I think Tara makes a great point. I think we can sit here and debate about these treatments. The truth is that many in the community, of course, they're in smaller practices or different practices, are not comfortable giving bispecific antibodies. And I think we all have to remember that when rituximab first came out, it did cause CRS. It just CRS didn't have a bad name back then. Now, because of CAR T, everybody is afraid of those kind of toxicities, but we have to re-educate the community to use them, because that's the best way to get more access for our patients.
It's just education.
Taming the bonanza, because they are coming, right? It is not just going to stay in our lymphomas with regards to bispecific, nor a lot of other cellular therapies. And with that, this has been outstanding discussion, as well as what I hope has been incredibly educational for you all. And I appreciate your presence and attention. Hello, my name is Dr. Matthew Lunning, and today I'm joined by Dr. Andriadis and Dr. Graf for this discussion on maximizing the possibilities in the evolving treatment paradigm for relapsed refractory follicular lymphoma, from optimal sequencing to shared decision making. Now, we just talked about sequencing. There's been an explosion of therapies in relapsed refractory follicular lymphoma, to the point where I sometimes think we were playing checkers with follicular lymphoma, and now we're really playing chess, where we have multiple different pieces on the board where we can actually be quite strategic on when we pull them out and how we use them to checkmate the disease, such as follicular lymphoma. And with that, we got to keep in mind that there are many different challenges in relapsed refractory follicular lymphoma, from the standpoint of lack of published outcome data with one therapy followed by the other, short or limited follow-up. We really have no biological insights or biomarkers. We've heard of POD24, and I think how POD24 has been like a little bit of Play-Doh, where we've kind of changed it to how we want it to be within clinical trials. We have incredible variation in treatment accessibility. We know we do a poor job of getting minorities or those underrepresented onto clinical trials. We need to do better, but then we need to publish that data in the real world experience. And we also have very limited data on how treatment affects the disease biology in regards to the response to the next class of agents. And it all comes back to that these agents have been approved, many of them on single agent phase 2s, so we have really no head-to-head trials comparing these recently approved agents. And so because of that confusion, there's an incredible amount of opportunity to discuss with my colleagues, my friends, Babas and Tara today. So with regards, I'm going to throw this one to Babas, to you. We heard about autologous stem cell transplant. There are many institutions that continued to do auto transplant in follicular lymphoma, but now we have small molecule inhibitors like zanubrutinib in combination with obinutuzumab. We now have 2 bispecifics. We have 3 CAR T cells, all in the relapse setting. How in the heck are we going to sequence these things?
Yes, Matt, this is the age-old question. What do you do next for a patient with follicular lymphoma? And are you changing the course, the natural history of the disease and the course of treatment if you do one treatment before something else? I think I speak for many people when I say that autologous stem cell transplant is not the most commonly used therapy for follicular lymphoma, and it's probably not a therapy that should be thought of early on nowadays in the setting of more effective immune-based approaches. I'm impressed by the data with EZH2 inhibitors, especially for patients who are EZH2 mutated. And so in our institution, we always do a baseline next generation sequencing for our patients. And if I know somebody has an EZH2 mutation, I will be switching them to that therapy early on in their relapsed career. Other than that, I think the immune therapies are the most exciting therapies right now, and we're accumulating data both with bispecifics and CAR Ts. Currently, the bispecific and CARs are third-line therapies for follicular lymphoma, but we all know that there are studies trying to bring the bispecifics earlier on in the disease course, and I think that's going to change the natural history of this patient. So at this time, I know that patients who've had CAR T can be effectively salvaged by bispecific therapies if they progress. And we're starting to see data for patients going the other way if they had bispecifics first. So I think of the bispecifics and CARs as interchangeable.
Very good. And Tara, you heard it here. So bispecifics, CAR T cells are moving on up and transplants moving on out. Can you remember the last time you referred somebody for an auto transplant for follicular lymphoma?
I was just thinking about that, Matt. I think it's probably been at least about 6 years, I would say, that I've probably referred my last auto. And don't get me wrong, those patients that I've referred for auto for second line follicular, and then in second line is when we were doing it, they did very well and are still doing well, but that is not where I'm going to go. I'll be honest, in my opinion, if you will, with these novel therapies that are around, that is not something that I am going to look to, which is, back then, something I never thought that I would be saying, but definitely, how I feel today. I think we're seeing, chemoimmunotherapy go kind of by the wayside. And I think, auto is kind of heading that way too.
We've talked a lot about clinical trial data, real world experience, but are we really getting that experience from the clinical trials, Babis, in regards to knowledge on how to sequence in relapsed refractory follicular lymphoma?
I think there's most of this experience is really individual institution or personal experience, let's say. There are clinical trials, there are retrospective studies really that are trying to address the issue of are patients getting therapy X doing better than when they got their previous therapy. And one of these abstracts was presented for the Rosewood study, which is the combination of zanubrutinib with obinutuzumab in the relapsed refractory setting. It's based on the premise that, historical premise that patients with follicular lymphoma do worse with each successive line of treatment with a decline in the progression-free survival. My personal experience, and I don't know, Matt, if you agree with that, is that has changed a lot in the last several years, where we're constantly finding studies where the next line of treatment is producing better PFS than the previous line of treatment, largely due to the variability of what the different lines of therapy are, since we have so many more options. In any case, in this study, they compared the PFS to zanubrutinib obina versus prior line of therapy, and they showed that there's a reversal of the curve, meaning that patients are getting a longer PFS with the subsequent line of therapy, if that's zanubrutinib or obinutuzumab, and also the earlier that it's used. So if they have 2 prior lines of therapy versus more than 2 prior lines of therapy, and the patients do better. It does suggest the trend that we're doing better with modern therapies, and patients are getting a pretty long progression-free survival on the treatments.
So Tara, in your experience, does the optimal treatment sequence change depending upon the patient's disease characteristics?
That's a really good question. I don't think we know enough to answer that yet. We talked about POD 24, we talked about trying to sort of define, who with follicular is going to be one of our early relapsers, or that one person who's going to just get in remission and never recur. And I don't think we're quite there yet. I think with the idea of true personalized medicine and being able to look at the microenvironment of each person with follicular and kind of what sets them apart from somebody else, I think will allow us to hopefully do that. We talk about different biomarkers or molecular studies like the EZH2, that is great, being able to do next-gen sequencing, but it's not like we have a whole panel of markers right now for follicular saying, okay, if they have this, you do this, and so on. I hope we get there, but I think what we're seeing, no matter which agent we're picking, even in that POD 24, the 4-line therapy plus groups, these patients are responding to these therapies. And I think that's what's important, that even if it's not quite the perfect selection based on what we know today, we're doing a really, really good job, and far better and far superior than what we were doing, just a few years ago.
I think that's well stated, Tara. Now, Babis, in this next question, we're going to do a little role play where I'm going to be Doc and you're going to be Marty McFly, okay? And we're going to hop in our DeLorean here, and we're going to fast forward to July 1st of 2029. And explain to me what you think the frontline follicular lymphoma is going to look like in July 1st, 2029, when we land our DeLorean kind of at your cancer center.
Well, yeah. I'm excited that we're referring back to the future. That takes me back to my adolescence. I think the field is very rapidly moving forward. Having said that, we're still using therapies that first emerged 20 or 30 years ago. So we still need to be cognizant of what's working in follicular lymphoma. I think we all developed an appreciation for the dark side, I should say, of bendamustine over the last few years, which is a drug that's very highly active and I still use as a frontline therapy. But we've seen higher rates of infectious complications. We've seen higher rates of complications from COVID. We've also seen problems with successful application of immunotherapies like CAR-Ts and now bispecifics, where patients with recent exposure to bendamustine have inferior outcomes. So if I had to guess, I would say that we'll be doing less chemotherapy in the future and we'll be mostly using immunotherapies and targeted therapies for this disease. There's already several studies underway in the frontline and second line setting of follicular lymphoma, doing what I call chemo-free, incorporating Revlimid, for example, with odronextamab in the frontline setting, or Revlimid with Rituxan, and then all three bispecifics, Epcori, odronextamab, mosunetuzumab in the second line setting. So I think that data will come into fruition, and we'll see that we can effectively move this therapy earlier on. So unlike in large cell lymphoma, I think CAR-T is going to be moved further back for patients who progress after hopefully many years of having achieved a long-lasting remission on these therapies. So I am excited about the future. I think many good things are happening in the field.
I think about this a lot because, I do have trials with, bispecifics in the front line. And I think about what this looks like for the future all the time, and why I think I had said earlier, why I really feel like we need to educate and to empower our community oncology colleagues. I do think bispecifics are going to be frontline. I think it's going to be, bispecific plus. So I really think that now is the time more than ever to prepare our colleagues for what this looks like, get them familiar with using, monotherapy and kind of the quirks around managing, because I really do think these agents are going to move all the way to the front line. And that's where the patients are, right? These patients are in the community. I think the time is now to get that education and that familiarity in place with these agents. So, when we hop on our time machine and go back to the future, that everyone is comfortable and everybody is able to use these drugs, safely, in all settings.
Well, there you go, folks. You had Tara and Babis's excellent adventure here today, making another movie reference for those of you Bill and Ted fans, where we've just shared an incredible amount of information and insight into the moving space, what is relapsed refractory follicular lymphoma. I thank you all for your attention and attendance today.